Once you have decided to bring the baby, the next question sounds like a duel. Misoprostol or oxytocin? Which one wins? It is the wrong shape for the question. Neither drug wins in the abstract because the method is not chosen by a head-to-head race. It is run through a set of filters that the ruptured membranes themselves set. The barrier is open, the infection clock is running, and the woman in front of you may already be ripening on her own. So we start where the reasoning is cleanest, with the drug the others are measured against, and let each alternative earn its place, or fail to. That anchor is intravenous oxytocin, and it earns the role by what it does and just as much by what it does not do. It does exactly one thing. It makes the muscle of the uterus contract. You start it low, around 1 to 2 milliunits a minute, and step it up every 20 to 30 minutes until the contractions are adequate. And because contraction is its only job, and because its effect fades within a few minutes of your turning the drip down, a uterus that starts contracting too hard is fixed by simply reducing or stopping the infusion. Nothing is committed that you cannot take back. Set that against the alternatives before we even meet them. A drug you can withdraw in minutes is a different kind of thing from a tablet already absorbed or a device already sitting inside the cervix. In the original large-term rupture trial, women induced with oxytocin had chorioamnionitis about 4% of the time, against roughly 9% when labor was left to its own pace. So oxytocin is not just controllable, it is effective at the thing that matters here, getting to delivery before infection climbs. The obvious objection is that oxytocin needs a ripe cervix to work, and women with ruptured membranes so often have a cervix that is long and closed. Surely, the thought goes, you must ripen first with a prostaglandin or a balloon, and only then bring on the oxytocin. But that instinct, imported from elective induction, does not survive contact with rupture. When you look specifically at ruptured patients, adding a ripening step ahead of oxytocin buys no advantage over going straight to oxytocin, even when the cervix is unfavorable. Hold on to that puzzle, because it is the hinge of this whole lecture, and the reason for it comes a little further on. So why does misoprostol keep getting proposed as the better choice? The honest answer is speed. Pool the modern randomized trials, 20 of them, nearly 3,000 women, and misoprostol shortens the time from starting induction to delivery by roughly 63 minutes. But two things sit on top of that hour and quietly hollow it out. The first is that the trials disagree with each other violently about the size of the effect. The statistical measure of that disagreement is about as high as it goes, and it could not be explained away by the route the misoprostol was given or the year the study was done. So the 63 minutes is an average laid over estimates that scatter all over the place. The second, and the one that decides it, is that the hour does not turn into anything a woman would feel. Vaginal birth within 24 hours? No difference. Cesarean? No difference. You have bought 60 unreliable minutes on a clock and changed neither who delivers within a day nor who ends up in the operating room. The trial that put a fine point on this is the one built exactly for this comparison. Misoprom. 305 first-time mothers, all ruptured within 12 hours. Oral misoprostol against intravenous oxytocin. Here, even the 60 minutes vanished. The time from induction to vaginal delivery was 11.9 hours with misoprostol and 11.8 with oxytocin. And the cesarean rates were within a whisker of each other, 20% either way. What did differ was on the newborn side. More babies in the misoprostol group received intravenous antibiotics, about 16% against 7, even though the rates of actual chorioamnionitis and proven neonatal infection were the same. So a fair way to hold misoprostol is not as better or worse, but as a different bundle. An unstable hour of speed, a genuine signal toward less postpartum bleeding, and in first-time mothers, a nudge toward more newborn antibiotic exposure. That is a trade, not a victory. And it is worth saying plainly that the evidence underneath all of this is thin. Small trials, mostly unblinded, with misoprostol doses and routes that vary from study to study. That variation is not a footnote. It is the reason no single minute count from this literature can be trusted. Now the part that looks, at first, like the field contradicting itself. And it is worth slowing down, because both sides are correct. One good randomized trial, Ahmed's, enrolled a mix of women and found overall no real difference in vaginal birth within a day, around 85%, whichever drug you used. But split it by parity, and a clear picture emerges. In women who had delivered before, misoprostol got them to active labor faster and to delivery faster, by about an hour. In first-time mothers, nothing. A second good trial, Bender's, enrolled only first-time mothers with an unfavorable cervix, and it leaned the other way. Oxytocin reached delivery faster, nearly 15 hours against 18. And in the women whose cervix had already opened even a single centimeter, oxytocin was 4.5 hours quicker. Its authors concluded that cervical ripening may simply not be indicated in a first-time mother whose membranes have ruptured. So one trial says misoprostol helps the multipora. The other says oxytocin serves the nullipora. The temptation is to average them into a mush. Do not. The parity is not the noise in the signal. The parity is the signal. To see why, you have to follow the biology of what rupture actually is. Rupture is not a passive leak. When the membranes break, an enzyme called phospholipase goes to work on the tissues of the membranes and the decidua, freeing arachidonic acid and driving up production of prostaglandins. And prostaglandin is precisely the class of molecule that misoprostol is, a synthetic prostaglandin E1. So in the hours after the waters break, the cervix is already being ripened from the inside by the woman's own prostaglandins. That single fact is the hinge I asked you to hold. Misoprostol does two jobs. It softens the cervical collagen and it drives the muscle to contract, while oxytocin only drives the muscle. In a first-time mother, the thing holding her back is the unripe cervix, and pouring in a prostaglandin from outside onto a cervix whose own prostaglandins are already switched on adds very little. So plain oxytocin keeps pace and often beats it. In a mother who was delivered before, the cervix and lower segment remodel easily. What she mainly needs is a strong, coordinated push, and a prostaglandin can deliver that faster than a drip you are cautiously titrating upward. Same drug, opposite verdicts, because the rate-limiting step is different in the two women, and the endogenous ripening reading of that split is a hypothesis, not a proven law. There is a natural challenge to make here. If rupture releases prostaglandins in everyone, why does any woman stay unripe and stall? The likely answer is that the release is partial and uneven, and a minority of women seem to make relatively little prostaglandin of their own. Those are the ones who sit for a long time after rupture and never really get going, the ones who respond poorly to almost anything and account for some of the cesareans. That is not a contradiction of the picture, it is the tail of it. And it is a large part of why the question, which drug is better, has no fixed answer worth memorizing. The biology genuinely varies from woman to woman. Which brings us to the tool people reach for when the cervix is truly unfavorable, and they want to ripen without any drug at all, the balloon catheter. Outside the setting of rupture, the balloon is chosen for a specific virtue. It carries no medication, and it physically cannot overstimulate the uterus, so it takes tachysystole off the table. In a woman with ruptured membranes, that virtue is answering a question nobody asked. Look at the numbers against oxytocin alone. The balloon raised intraamniotic infection from about 3% to nearly 10%, a more than threefold increase. And the mechanism is exactly what you would fear, a foreign body drawn up through a cervix whose membranes are already open, carrying the ordinary bacteria of the vagina up toward an amniotic cavity that has lost its seal. The hazard the balloon so elegantly avoids, tachysystole, was never Prom's hazard. The hazard it introduces, infection, is the very clock we are trying to beat. Now, a fair reader will notice that when you pull the balloon against all the drug methods together, the infection signal softens and its confidence interval crosses 1. But that pooling mixes in the prostaglandin comparators and dilutes the exact contrast that matters, which is balloon against oxytocin alone. And there it is real and threefold. This is why the guidance is blunt. Cervical whitening balloons should be avoided after rupture. Name the hazard the open membranes create, and it disqualifies the device whose whole selling point is a danger this situation does not have.
There is one more way to squander everything we have just reasoned through, and it has nothing to do with which drug you loaded. It is stopping too soon. A uterus that is ruptured and unripe has a long runway by its very nature. And if you look at a slow latent phase and call it a failed induction, you convert a woman who would have delivered vaginally into a cesarean, and you erase the benefit induction was supposed to give. The guardrail is a floor on your patience. In the latent phase, do not declare an induction failed until she has had adequate contractions for at least 12 to 18 hours after the membranes ruptured and the oxytocin began. The timing data trace the same shape. The latent period that best avoids a cesarean runs past 12 hours, and stretching the practical latent phase from 12 out to 24 hours in low-risk ruptured women cuts cesareans by about a third without raising infection or harming the newborns. The honest tension is that every one of those hours also feeds the infection clock, and you do not get to pretend otherwise. You hold both at once. You owe the induction real time before you quit on it, and you owe the mother a watchful eye on that fourth clock while you wait. The guardrail forbids a premature cesarean. It does not license waiting forever. So the method question was never a duel, and answering it as one is how people go wrong. It is a cascade. First, you strike out the tools the ruptured membranes forbid, the balloon for the infection it ferries in, and misoprostol wherever a uterine scar or a grand multipara makes any prostaglandin dangerous, which is the same reason a scarred, ruptured woman gets pushed toward a careful, low-dose oxytocin. Then you anchor on oxytocin, the drug whose only job is contraction and whose effect you can take back in minutes. Then, and only then, you consider adding a prostaglandin's ripening, and you add it to the woman whose body has not already ripened itself, the multipara it tends to help, not the first-time mother it rarely does. And whatever you have chosen, you give it a full and honest latent phase before you call it beaten. Oxytocin is the anchor because you can take it back. Every other tool earns its place only by clearing what the open membranes forbid, infection first, and only after you have given it a real latent phase to work.